Welcome. I know that some people are still joining into the Zoom, but I would like to go ahead and get started. So welcome everyone. We're here at the fourth and final day of the 12th Annual Symposium on Global Cancer Research. As people are logging in, I'd like to go ahead and again thank our excellent speakers and presenters and moderators from yesterday. We heard from the presenters of 8 of the 16 top scoring abstracts from this year's call for abstracts. And we got to hear about a multi-country cross-cultural research trial network that really highlighted the power of collaborative partnership. By the end of today, you will have heard from 58 speakers from 20 countries. You will have viewed over 100 scientific posters highlighting work in 35 countries, and you will have interacted with hundreds of participants from around the world. We're grateful to host this event virtually each year to permit this level of diverse representation and inclusivity. And we're very thankful to each of you participants for actively supporting this event. So thank you. In case today is the first time you're joining us, I'll reintroduce myself. My name is Mishka Kohli-Sira, and on behalf of our director, Dr. Satish Gopal, who you will hear from later today, and all of us at the Center for Global Health at the National Cancer Institute and the ASGCR Scientific Steering Committee, it's my pleasure to welcome you today. As per usual, I'm going to run through some logistics before we get started. So please note that the symposium is recorded and we will make the recordings available after the event. We are keeping participants muted throughout the event. You can use the chat function at the bottom of the screen to post questions and comments throughout the day. And also just note that you can, if you have issues with the audio, or video, there is an arrow button to the right of your mute and stop video video screen at the bottom of the screen, and you can adjust there or stick a note in the chat and we will try to assist you with it technically. Also, please note, and we're very grateful to our language interpreters, we are offering simultaneous interpretation in French, Spanish, and Portuguese throughout the course of the symposium. You must select the globe at the bottom of the screen for interpretation, and please select English, French, Spanish, or Portuguese. Also, please join us on social media. You can use the hashtag ASGCR24 and follow us on X, and you can tag us at NCI Global Health. And now it's my pleasure to pass the mic to our ASGCR Scientific Steering Committee member, Dr. C.S. Pramesh. While this is Dr. Pramesh's first year as a member of the Scientific Steering Committee, he is not new to ASGCR. In fact, Dr. Pramesh is the recipient of the 2022 Rachel Perline Award. Hopefully, many of you had the chance to see his quite memorable keynote address that year. In his day job, Dr. Pramesh is the director of the Tata Memorial Hospital in Mumbai, India, and convener of the National Cancer Grid. And you could read much more about his extensive experience on the ASGCR website. So without further ado, Dr. Pramesh, I invite you to give today's opening remarks. Over to you, Pramesh.
Thank you. Thank you, Mishka, for the kind introduction. It's an absolute pleasure to be part of this ASGCR. And thank you to all the attendees for joining. It's been stimulating discussions over the last 3 days, and I'm certain that this will hold true for today as well. We've had a record number of abstracts being submitted, record number of posters being highlighted over these 3 days, and hopefully record number of participants attending over these 4 days as well. So what makes ASGCR unique is the fact that this year we've sourced plenary session topics from various stakeholders, very diverse topics, as those of you who attended the previous 3 days might imagine. And we have yet another very important and diverse topic today that will be discussed that's of extreme relevance, especially in today's world of precision oncology. Over the years, I've seen the ASGCR grow from just being an add-on to the CUGH meeting to an independent one in its own right, and over the years has had increasing participation both by way of faculty as well as participants who've been part of this meeting. There are very few things that we need to be grateful to COVID for, but one of the important changes that have happened with the ASGCR has been the virtual format and the increased reach that it has been able to achieve since it turned virtual, enabling participation from folks who would not otherwise have been able to attend. This is also an excellent opportunity for early career investigators' research to be showcased. And one of my personal favorites over the last 3 days was the first day where we had some outstanding posters from early career investigators on extremely diverse research areas, starting from HPV to mobile technology to basic science research to implementation science, the entire spectrum of cancer research being represented in these early career research posters. As the convener of the National Cancer Grid, I feel extremely proud to be partners with the NCI Center for Global Health, along with other global organizations. For those of you who are not familiar with the National Cancer Grid, we are a network of over 340 cancer centers, research institutions, patient groups, professional societies, and philanthropic organizations, and probably the largest cancer network in the world, with the mandate of having uniform standards of cancer care to build capacity to meet the increasing burden of cancer, especially in low and middle income countries, which, as all of us know, will face a disproportionate part of the increase in the cancer burden over the next decade or two, and to be a ready platform for collaborative, multicentric cancer research and to influence cancer policy globally. Some of the initiatives that the Cancer Grid has done is to have resource-stratified treatment guidelines, quality improvement initiatives in various aspects of cancer control, virtual tumor boards, virtual expert opinions, pooled procurement to reduce the cost of cancer drugs, online and blended learning initiatives. You must have heard about the research methods training, the Credo workshop, and more recently, establishment of the Center for Digital Oncology and the Center for Global Oncology with international memberships. So the reason I mentioned these initiatives is the clear alignment that we see with the NCI Center for Global Health work on reducing disparities in cancer care. And I use this opportunity to offer this open invitation to become international members of what is now becoming a global oncology movement under the National Cancer Grid. To come to today's session, which has a really good agenda. We started off and we completed the networking and the post walk on Gather, which is it's an extremely intuitive tool to use and very interesting. The plenary session deals with building cancer genetics infrastructure in resource-limited settings with a multinational perspective. And you'll hear two examples from Rwanda and Trinidad and Tobago, which stand out as exemplars that many other countries and regions could use. This will be followed by Meet the Abstract Authors, which is an interactive poster session, again on Gather. And the highlight of today's sessions, which will be the Perline Award presentation and the keynote address by Benda Kitaka. And we'll close with closing remarks from Satish. But for now, it's a pleasure to introduce and hand over proceedings to Dr. Jerniba Parkinson, who's a PGY3 resident in the Department of Internal Medicine at the Warren Alpert Medical School of Brown University. And importantly, and what's relevant to this meeting, is also the Executive Director of the Caribbean Alliance to Control and Prevent Cancer from the Trinidad and Tobago region. Over to you, Dr. Parkinson.
Hi, everyone, again. My name is Geneva Parkinson. I'm so glad that you're able to tune into our session today. We're going to talk about building cancer genetics infrastructure in resource-limited settings. We give you a nice multinational approach and experience, both from Trinidad and Tobago and from Rwanda. So a little bit of our layout today. So we're first going to start off with Dr. Bishkovsky, who's going to talk about a Cancer Genetics Foundation introduction. And then we're going to turn over to our first country, in Trinidad and Tobago, where I and Dr. Ellie and Mike, we're going to talk about investigating breast cancer genetics and our approach to a project we did a couple years back. And then Dr. Mike's going to give a local perspective on how to approach international clinical research. And then we're going to turn over to our second country, Rwanda, where Dr. Manarakisa is going to give a talk about Rwanda Cancer Genetics Initiative. And then we'll have Dr. Fidelo give his perspectives on healthcare providers in Rwanda on cancer genetics. So with that, I will turn over to Dr. Pichkovsky, and I have your first slide here.
Hi, good morning, everyone. I'm excited to be here today for this forum and talk with experts on how we can support and build cancer genetics infrastructure in resource-limited settings. So cancer genetics has evolved over the last 3 decades. In the United States, we are now offering multi-gene panels to patients diagnosed with cancer. So let's go to the next slide. These panels include up to 100 genes. When we identify a pathogenic or likely pathogenic variant in a cancer gene, each gene is associated with a different cancer phenotype. For example, the BRCA genes are associated with breast, ovarian, prostate, and pancreatic cancer, and the cost of these tests has come down. They are slightly more expensive than like a COVID PCR. So historically, cancer genes were associated with Ashkenazi Jewish ancestry. So let's do next slide. However, we now know that cancer genes can be identified in individuals of any race, ethnicity, or ancestry. So the last NCCN guidelines from 2024 had a small footnote that I would like to highlight. So let's go to the next slide. So in this footnote, they emphasize the evolving literature that people of Polish, Icelandic, French Canadian, Spanish, Mexican, Central and South American ancestry, or those with Bahamian, Hungarian, or Brazilian ancestry have enrichment of cancer genes. So my message today is I firmly believe that hereditary cancer genes are present in individuals of all races, ethnicities, and ancestries, and we should consider genetic testing in anyone with a cancer diagnosis. Next slide. In fact, okay, next slide, please. Yeah, thanks. In fact, ASCO and the Society of Surgical Oncology recently released a statement where they emphasized cancer genetic testing, specifically BRCA and PALB2 testing for all newly diagnosed breast cancer patients, all breast cancer survivors where the results may impact their survivorship care, those with locally recurrent breast cancer, or those with greater than 1 breast cancer diagnosis. Next slide. So my main take-home point is that we should not let provider or patient biases around ancestry discourage us from offering testing to diverse patients on an international global scale. It is important to note that since the discovery of hereditary cancer genes in the 1990s, guidelines have evolved from testing patients with specific cancer subtypes like triple-negative breast cancer, or those with a family history of cancer, or those with Ashkenazi Jewish ancestry, or a young age at a cancer diagnosis, to then recommending testing anyone with cancer who may benefit from a PARP inhibitor, to now we're kind of recommending testing anyone with cancer where testing would influence survivorship care. Next slide. So hereditary cancer genetic testing influences cancer prevention strategies. These include risk-reducing surgeries, like a risk-reducing or preventative mastectomy, risk-reducing bilateral salpingo-oophorectomy, risk-reducing gastrectomy for patients who have CDH1 mutations, or even a risk-reducing colectomy. We also use risk-reducing medications or chemoprevention. Patients may also be advised to receive high-risk screening with breast MRI plus mammogram, early colorectal cancer screening with colonoscopy, or pancreatic cancer screening. Genetic testing results also inform cancer treatment decisions, and options for a bilateral mastectomy may be appropriate if a patient has a high contralateral breast cancer risk. Genetic testing results also influence access to targeted therapies like PARP inhibitors for patients who have BRCA or PALB2 mutations. So in Massachusetts, we also offer IVF and pre-implantation genetic diagnosis and embryo selection to our couples affected by cancer genes who are in the process of family planning. Cancer genetic testing is also just important to care for families. And so if an individual has a cancer diagnosis at a young age, I think it's important to identify those who have a cancer gene and make sure you're caring for their family members. Next slide. So many groups now offer guidelines for managing pathogenic variants in cancer genes. These include NCCN, ASCO, ESMO. There are also risk calculators like Ask2Me or CanRisk that can aid in patient education. Next slide. And yet, we know access to cancer genetic testing is limited worldwide, which is why we're going to be talking today about ongoing efforts to address this challenge. So next slide. So a few years ago with colleagues, I worked on a call to action proposal where we advocated to expand cancer genetic testing in low and middle income countries. We first proposed to normalize and destigmatize individual cancer susceptibility. Then we emphasized the importance of training and educating healthcare providers in cancer genetics around the world. And then third, we recommended to develop local patient-centered systems for high volume testing of cancer patients. So on this point, next slide. Okay, yeah, next slide, sorry. So on this point, I want to highlight the ProGen study, which was led by my colleague here at Dana-Farber, Huma Rana. Historically, when patients are referred to genetic testing, they meet with both a genetic counselor and a physician. So this requires complex scheduling and time of 2 healthcare workers, and it's resource intense. So in the ProGen study, video education pre-test counseling was compared to in-person genetic counseling. And in this study, males with prostate cancer who we've referred for genetic testing were randomized 3-to-1 to video education counseling versus in-person genetic counseling. And there were 662 males in the study, and the median age was 66. And 99.3% of the video education participants completed genetic testing versus 98.6% who had in-person genetic counseling. And both groups had high satisfaction after the intervention. And then among participants with pathogenic variants in the genetic testing arm, they had slightly greater distress at 1 month, but this was not statistically significant at 4 months. I highlight this work because I think this is something that's scalable in other settings. So next slide. So to kind of conclude, we do recommend countries to develop country-specific guidelines for cancer genetics care. And we also hope to galvanize international support for hereditary cancer genetic testing. And this also involves encouraging the WHO and other stakeholders like the NCI to prioritize cancer genetic testing and offer support for the perceived barriers of coordination and consensus. And I just want to also bring awareness that hereditary cancer genetic testing is not on the World Health Organization's essential diagnostic list. And I think this is something for us to ponder as a need going forward. So I just want to thank you for your attention, and I'll transition now to Dr. Parkinson.
Thank you again so much, Dr. Bishkowski, for that nice introduction and for highlighting the need for more infrastructure, no matter the resource setting, for cancer genetic testing, counseling, and really including that into medical care. So we'll start off by giving, we'll start for the first country, Trinidad and Tobago, and we will go through the two countries, Trinidad and Tobago and Rwanda, and how both settings adapted their various workflows to incorporate cancer genetic testing through projects. So first with Trinidad and Tobago, so hi again, my name is Geneva Parkinson. I'm a graduating resident at Brown University, heading to start my HEMONC fellowship at Stanford this summer. But I've been doing breast cancer genetics work in my home country, Trinidad and Tobago, for years, and most of the work is done through my nonprofit, the Caribbean Alliance to Control and Prevent Cancer, which is situated in Trinidad and Tobago. So just to give a little bit of background, with the United States compared to Trinidad and Tobago, looking at sort of the statistics, so you can see that Trinidad and Tobago is very tiny compared to the population of the United States. But what is really stark that just kind of jumps out of you is the age of diagnosis. So in Trinidad and Tobago, our average age of breast cancer diagnosis is between 45 to 50, compared to 61 years that is seen in the United States. And when I first saw the stat back in 2015, 2016, the BRCA mutation prevalence was not known at all. So despite this young population, we didn't know how many folks were, how many patients had the BRCA mutation. So what do? So we set out to do a project between 2016 and 2019. And basically the question was, what is the germline mutation rate and spectrum within the Trinidad and Tobago breast cancer population? So we recruited 249 female breast cancer patients who met the NCCN criteria for further genetics and counseling and testing. And then we interviewed them about their personal breast cancer diagnosis and their family history. We collected saliva samples, and then we turned the results through genetic counselors. So what I really wanted to take from this session is what was sort of the team players that we put together to make this project successful. And I hope that you can get from that session, like who you'd need to bring on board to maximize your chances of success should you want to put together cancer genetics, whether it's a clinical effort or a research project. So I broke it up into 3 places. So first, the recruitment and pre-test counseling, the cancer genetics testing, and then the post-test counseling. And when I say the team, what do I mean? So again, my nonprofit, the Caribbean Alliance to Control and Prevent Cancer, that being the hub that kind of brings together all the team members. You have your local hospital partners, so the Cancer Center of Trinidad and Tobago, the Sandy Grande Hospital. You have the regional health authorities. These are the folks who work with you to make sure your ethics committees are, aligned right, so you can properly do your research. Color Health that provided the cancer genetic sequencing to make the project successful. And then at the time of that training, I was doing my training at Yale School of Medicine. So Yale was the academic partner. All right, so first let's talk about the recruitment and the pre-test counseling. So I want to say that first, you need a local project coordinator. I think in the day and age of after, because of COVID, I think a lot of international sites are very comfortable now with telemedicine and virtual, which is a good thing. But it also lends, I think, from our end to wonder if we can do a lot of things virtual. And I would say that you need someone on site, and this person is the one who actually sees everything on the ground, that sees any issues that might come up, who would see the workflow to anticipate the problems that might come up. So you definitely need someone on the ground. Before you even start planning anything, you need to talk to the local oncologists and the medical staff. They will tell you how to shape your project so that everyone benefits, so that you don't run into obvious problems that everyone gets stuck on, so that you don't end up your project ends up, crashing and burning. They will give you the heads up and sort of help you shape your project so that, again, everybody maximizes this opportunity. And then the last thing I put here is the research assistance. And I really wanted to highlight this because I think that every time when we plan projects a lot, coming from academic settings, I think that we have in mind academic settings where research is very well integrated already to the clinical workforce. So you don't think of certain things that might come up when you're trying to adapt to a project that's mostly clinically driven, that is not really built to have research within it. So the manpower that you need, sometimes you underestimate what that might be. So I think really look at the scope of what your project and what your clinical effort might need, and definitely give the appropriate amount of manpower. And specifically for the recruitment and pre-test counseling, what are these folks doing? They're doing your recruitment through physician referrals, chart reviews. They're conducting pre-counseling sessions in person. They're reviewing basics of genetic testing and study protocols, and then they're collecting family and personal medical history. So the actual genetics testing, and I think this really applies for any time you do a study or a clinical effort that involves biospecimens, you need to find a industrial partner that's going to help you work with your specific site and be able to be adaptable and be able to be flexible to accommodate what your needs might be that might not mirror what they're accustomed to. So that they should be able to sit down and work with you. And we worked with Color Health at that time, and they were great to sit down with us and be like, okay, what is the flow in Trinidad and Tobago, and how can we, help partner and align with that? So I think that's the first important thing. The next thing is your career partnership. And I feel like this is a really important point that gets very overlooked. I think, we do a great job of collecting the samples, and it's time to ship them out. And then you take your package to the courier and they're like, what is this? So we used FedEx at the time because they were totally okay with saliva samples. Make sure that your courier is okay with what you're shipping, and make sure you know the specifics of the package that you need to collect. And again, you can work with your industrial partner so that they can send you materials that works with the courier. So for us, it was sort of the samples in the box, and then the samples in the baggie with the box in the box. So they were able to pre-package us to meet our needs, so that it worked really well with FedEx, so we didn't have to do anything like that, and that took a lot of load off for us. And then lastly, the return of results and post-test counseling. And again, going back with your local industrial partner and then working with the local oncologist and medical staff, I think this is where you really show the benefit of your project to your local partner, being able to give back results that are useful in a way that is able to be used by the local team, used by your patients, that's able to be clinically beneficial for them, for their care. We used color that was a clinical grade, so we were able to, using genetic counselors, give back tests that patients could use for their care. Again, I put in the research assistants because again, you got to match the research assistants to the workforce that will come with your research project or your clinical effort. And then future work. So as Dr. Petrossi was talking about, definitely using automation for certain things that you can actually, stuff you don't have to have an in-person person all the time. So like for pre-test counseling, you can use video efforts, virtual sessions, standard literature. So we're now in the process of looking to see how we can implement that in the Trinidad and Tobago workflow to, sort of maximize the resources that we already have. And then I put this picture on here. So these are pictures of our project, and I really wanted the one thing, if anything, you can get from my section of the panel is that it's, one project, one team. I think when you're doing your proposals, it's really nice to have, the little circles where you're like, this is the US hub, or, this is the Canadian hub, and these are our local sites. But I think when in practice, and everybody needs to be everywhere. And I think it's very important for, for everyone to sort of see what the other persons are doing at the different sites. And I say this because, it was really helpful, like down here for Alicia, who is now the Chief Scientific Officer at Color Health, to come down to Trinidad and Tobago and see, the work that we were doing there, and seeing how our workflow was and what the logistics we were working with. And then up here, this is when I went to Color. So I was able to see their lab. So when they say things like, hey, we cannot do this in our lab, it's impossible. Like for me, seeing the lab with my own eyes, I was like, okay, yeah, they're right, they can't do this. So it helps me with planning with the project as well. This is another picture of us here in Trinidad and Tobago. And then this is a picture of all of us at ASCO. We were presenting our poster with all the results. So yeah, so one team, one project, and thank you. So I will take this time to transition over to Dr. Elaine Mike.
Hi, good morning, everybody. So as you said, I'm Dr. Kelly Elaine Mike. I am a clinical oncologist and also the medical director at the Cancer Center of Trinidad and Tobago, which is the largest and our oldest cancer center in the country. So I'm going to ask to move to the next slide. Okay, so Dr. Parkinson would have spoken a little bit about Trinidad. So we are located between North and South America. We are in the Caribbean Sea. We are the two most southerly isles of the Caribbean. We're just north of Venezuela. The population size is about 1.4 million, and we have a total area of about 5,000 square kilometers or 2,000 square miles. Not very large, but one of the larger islands in that neck of the woods. The national statistics have breast cancer as our #1 cancer for incidence overall among all cancers. But it's second in mortality, second only to prostate cancer, but still #1 in mortality for women in Trinidad and Tobago. Our institutional stats, we see that the majority of patients tend to be about stage 2 or stage 3. And then we have more or less an equal distribution in terms of patients with stage 1 and stage 4 for the breast cancer. The number of oncologists, so medical and clinical oncologists in the country is approximately 14. So it's a ratio of about 1 per 100,000 inhabitants to the country. Next slide. Right. So when we approached getting the project going, I wanted to put out some practical suggestions or recommendations based on our local experience, but I think that they can be translated to other settings as well. The main things I've wanted to focus on was, one, read the room, know your audience, and then understand the system or the framework that you're working with. So in terms of reading the room, I think it's always a good idea to get in there and have your discussion with your stakeholders. Find out what the level of interest is, find out who the allies are, who are like-minded stakeholders, and have a similar level of concern. You use your stakeholders to also help you identify the challenges that exist so that you can help to frame your narrative, find out a little bit about the existing resources so you can learn how to build on those resources so that you can present it to your audience. Now, with your audience, you're looking at getting your advocates together. So these are the people who are collaborating with you, the NGOs, the other organizations related to cancer in the country, and identify who your decision makers are, because they're the ones that are going to help you take this to the next level. The understanding of the framework is very important because it is going to vary from country to country. So Trinidad and Tobago, for example, has a universal healthcare system where patients can access many services for free within the healthcare sector, but it also has a private component as well. Besides that, in terms of the approval levels, who you're going to approach and who has to give you the buy-in and the approval to move forward, it's a tiered structure. So we have the institutional level, which is where the hospital is situated. But the hospital is usually one among a few other hospitals that are within a particular region. So our region, for example, was the Northwest Regional Health Authority. So the institution reports to the administrative board at the Northwest Regional Health Authority. So approval has to come at the institutional level, from the regional level, and then the regional authority also reports to the Ministry of Health. So understanding that alliance between and that link between the different pathways is very important to knowing how you're going to approach as well the process as you go forward. Next slide. Right, and then it's always very important for me. I like to approach it for getting the reason for the no. So why would anybody, a policymaker, be not interested in approving or supporting the project? What are the reasons why, if I knock at that door, they want to keep that door closed, or if they open it, they're just going to close it back? A lot of those, and I think that's in almost any setting, it comes down to financial, so money. Who is going to fund the cost for the projects? Who's going to help you pay for the tests that need to be done? There are issues also with ethical concerns. So on our end, there was a question of, for example, if the sample was going to be taken, would it be used for anything else? if the sample was going to be discarded after. So making sure you understand where their concerns are helps a lot in terms of how you're going to frame that pitch or frame that discussion or frame that narrative. I put the unknown in there because that's a realistic challenge that we've met as well. Because it's something that's never been done before, some people are just quite uncomfortable with the unknown. So getting in there and, showing that this is something that has been done in other places, getting people more comfortable, more used to having the discussion about introducing something like this in a new setting, increases awareness, and increasing the awareness also helps to get the buy-in that you need. I put the egg in the face comment because one of the concerns that we picked up as we went along was the question of, well, if I offer this test in the country, and then, from the results, we determine that we need to offer another procedure. For example, we need to suggest or discuss having prophylactic oophorectomies. Do we have things in place to make that happen? Because the last thing that a policymaker wants to do is to put something in place to offer one particular thing and then not be able to follow through. So knowing what those concerns are and starting to already put things in place to make sure that you can address the next steps also helps a lot with the comfort level for the people that you need to buy in to what you're trying to introduce. And then when you go through that process and you kind of start answering all of the questions for the no, you end up with the, well, why not? And the why not is the place that we want to get to, because then that's the time where people start saying, well, okay, you're right. Why not? Why can't we make this happen? Next slide. Okay, so the timelines for reactivity are extremely important because, you get your project going, you're all excited, but realistically, we're working within the limitations or within the framework of a facility or an institution that may be different from where we're coming from. So understanding how that works out is important. So and from the ethics point of view, for example, do you have to get ethics at just one level? Do you have multiple tiers, multiple layers where you have to make that happen? So the institutions may have its own ethics board. The regional health authority, in our case, the body that they report to, have their own ethics board. And in our framework, the Ministry of Health has its own ethics board as well. And then you also need to know, do you need to get approval from each of these levels, or is it automatically implied if you get approval at the highest level? And can you apply in tandem? Can you apply to everybody at the same time and they go through the process? Or do you need to have the approval at one level before you get to the next? So is it going to be a domino effect? It's extremely important. It's also important because each of these different ethics boards sometimes have a different frequency with which they meet. So we had some boards that met every month. We had boards that met every 3 months. We even had ones that met every 6 months. And then the timelines of how they met within the year can vary. So understanding the frequency with which they meet, understanding whether there's a prerequisite for approval from one board to the next, helps you kind of start planning out your timeline in terms of how quickly you can make things happen. Because of course, you've got a lot of moving parts in trying to get the support from the NGOs and the collaborators and so on. And you want to kind of make sure that everything just fits in place so that it works as seamlessly as possible. I mentioned know the system constructs for accessing patient data, because if you're identifying the patients that are going to meet the criteria for your project, how are you going to do that? So a lot of the systems are still paper-based, which means that you literally will have to manually go and pull the patient's file, go through the patient characteristics to make your determination. Dr. Parkinson would have mentioned about manpower. So if you have a paper-based system, it means that you're going to need more manpower to be able to help you access or pull the patient's files faster than if you had a hospital information system. So for example, in my institution, we started our HIS in 2019. And so once you have the HIS, then it's a lot easier because you can put in the parameters that you're interested in and they can automatically pull up your patient. So having an idea too of what that is within the institution that you're working with is going to be very important for you to plan your manpower and also to plan your timelines in terms of how much time you need to be able to access the appropriate patient files to move your project forward. And then I mentioned about the specialty staff available. So if you want to do follow-on interventions such as prophylactic procedures, do you have the skill set available and where is it located? I say where it's located because it's our experience that it's easier to sequence patient follow-on care if it's within the institution. So we have a women's surgical unit. And so if we needed to have any procedures like a contralateral, a prophylactic mastectomy, we could automatically have a discussion, multidisciplinary discussion within the institution, so that we're able to kind of get the timelines for the patient to fit in nicely, as opposed to if you now have to refer your patients outside to different institutions, sometimes you can experience a timeline. So that's also important in terms of planning. Also in terms of what is the workload at your center. So if you're talking about countries where your oncology specialist density or your surgical density, that's the number of specialists you have for the number of patients, is quite low, that means that you could have a large workload already with patients just having to get their oncological procedure. And now you also have these patients where you might want to consider these prophylactic procedures. How can you sequence or fit all of that in? So all of those different factors do have their role, do impact overall these timelines for reactivity, these timeframes for reactivity, and they're very important to consider as you're moving forward with the plan. Next slide. And then what I always want to say at the end is don't underestimate the power of the man on the moon. So policymakers, clinicians as well, you know, we want the best for our patients, and we want to offer them all of the new procedures that are available. Legacy is very important for policymakers. And so we can be motivated to be the first one to offer or introduce a new procedure that can add benefit to patients' lives. And so I like to use that as a motivating factor as well when you're having those discussions, that, you know, this is a legacy that you can leave behind for the country, for your institution. This is something that you can build on in the future. And this is something that is potentially scalable from the institution at a national level as well. So thank you, and I'm going to hand back over to Dr. Parkinson.
Thank you so much, Dr. Elaine, Mike. So you've heard from the two of us for Trinidad and Tobago. So now I will turn it over to Dr. Manarakisa, who's going to start the Rwanda experience.
Thank you, Geneva, and thank you for actually spelling my name right. My name is Eshel Manirekiza. I'm a clinical oncologist at the King Faisal Hospital in Rwanda. I'm currently based in Chicago for 1 year, learning and being supervised by Dr. Fumiolo Pade. So I'm going to essentially go through the work that we've been doing for a few years and try to address a few of the questions that have been, addressed in the chat by the work that we're doing. Next slide. So the first slide, if you run through, Rwanda is a very tiny country in East Africa, so tiny that you have to write the name in either of the two oceans close to Africa. It's now written in the Atlantic Ocean. Usually it's by the Indian Ocean as the country number 2 up north from Burundi. It's tiny, true, but it's the size of Maryland, but it's the highest dense and the most densely populated country in the continent at the moment. We still have issues of any other, low resource income, low resource setting, really, of 1 per million doctor per population ratio. And we have about 14 oncologists in the country for 13 million population. But it's, growing, and we hope we can do better in the next few years to come. Next slide. So the few things that drove us to think of this was, if you look through most of the cancer genetics related literature around the country and most of the countries in East Africa, there were interest-driven studies that essentially looked at specific alleles, specific genes, small population size and so on, and we really lacked guidelines-driven, something that had population and families at the core. And also we still have an issue of genetic counseling. This is a question that has to be answered pretty much all the time. But also we need to think of how to go from a research-based And we still think about it, how to go from a research-based practice to a clinical practice, and to essentially change this into a framework that allows people to, engage with genetics on a daily basis in the clinics. That involves, engaging with insurance, as some of the questions I've asked, that engages with essentially getting the labs capacity in the country, that also engages having genetic counseling in country. And I'm going to essentially show you how we've been thinking about this. So the next slide essentially shows, our timeline. In 2018, this is a slide that I've been discussing before, and it just brings things into perspective. So our president traveled to the Davos village in Switzerland for the WEF meeting, and he heard the precision medicine initiative by the World Economic Forum, and he was interested. In the following year, some discussion between the World Economic Forum and the government of Rwanda discussion started that essentially wanted to go through leapfrogging initiatives. So that was essentially things like how to go to precision medicine when a patient, random patient with a public insurance doesn't have access to traditional chemotherapy, for example. So this was bold, this was unique. And a fellow was sent to the WEF headquarters and learned a little bit about policies and ethics all around precision medicine. In 2020, some of us got our hands dirty, wrote the grant, got it, and also wrote the protocol and some adaptations to the NCCN guidelines to essentially fit our population. And then later on, when we realized, as much as we want to do this, we don't have genetic counseling capacity, we thought of a short course online that can essentially discuss genetic cancer risk assessment and a few things about counseling. So this has helped, but the online course was complemented by another live course in Kigali in April 2022. But the website is still there, and we had about 1,000 people join in for about 6 sessions. So the website is still there and is still live and working. So in April 2022, we were able to launch our study, and we were able to complete in February 2023. But to answer a few questions, we also used an international lab. We had a subsidized price, and we had to go through what Geneva, mentioned about shipping and platforms and so on. But the time to get the results back and to analyze and so on, the study right now is at the time of being reviewed at one of the Nature partner journals out there. So we're doing our best, but we've learned a lot, and we're trying to address all of that here. The next slide essentially discusses about our platform, which is what I want to really discuss about. So we thought, how to integrate all of this away from research-based to clinical-based, but this is something that is, this is a journey pretty much. The next slide essentially shows you where we are. If you go to it, yes. So we're still at the level of, we've identified patients. We've done a bit of genetic counseling together with teams from the Dana-Farber, and we also did the genetic testing. We've done informed consent. We've done the genetic counseling. We've done the data privacy platforms, and thinking of biobanking and mutation curation has been done already. But the journey here is to start thinking of, interventions in prevention, start to think of monitoring, start to think of diagnosis and treatment, start to think of siblings and relatives of all of these patients, but also engaging chemoprevention, engaging imaging and surgery radiation for risk reduction as risk reduction intervention. So this is a journey, and this is something that is guideline backed, and we hope this is something we can work on and carry on as we move forward. So a few of the findings that we have so far on the next slide. So one of the things that we did was to essentially adapt to our population. So this is the NCCN guidelines from 2021, and most of these things have changed already. The age for triple negative breast cancer has changed from 61 as the limit to every triple negative breast cancer. We definitely do not have Ashkenazi Jewish population in Rwanda, so we've removed that. The next slide shows what we based on to do prostate cancer, adaptation. And then the next slide shows what we based on to have our population. So as you can imagine, with our story with the genocide in 1994, most of the family history from our patients in Rwanda is truncated. So we do not have as good family history that shows patterns. So what we based on really was age. If, for example, you are below age 45, or you had some family history and you are below age 50, or at the time, once again, in 2021, you had below 61 and triple negative breast cancer and male breast cancer, you were eligible. If you were 65 and you're a man and you have prostate cancer or metastatic disease at any age, very high risk group, at any age, you are eligible. If at any point you had a positive family history, regardless of age, you are also eligible. But this was very relative because we knew that most of our patients did not know about family history. And this is another thing that we probably need to think about whenever we think of genetic counseling capacity building in low resource settings. Next slide. So we had a plan to enroll 400 patients overall in 1 year. We tried, I'd say, because we probably have, if I recall exactly the numbers, we probably have something like 83% participation rate. We had most female breast cancer, 196 male breast cancer, and 199 prostate cancer patients. We had issues that most of studying centers would have. We had failed tests, we had labeling errors on the containers. And then some patients returned for testing, some others declined completely. That's another thing, it shows that maybe we did not do a good pre-test counseling. Patients have other priorities, that's another thing. And maybe also we really have to be humble and say that we do not know much about our patients. We do not know what drives them, what makes them come to seek healthcare and all that. So these are things that we've taken forward in our next steps. So we ended up with a sample size of 342 tested and with analysis ready. So this study is still under review. And the next slide shows a bit of our findings. I did not show everything. So our age ranges really for breast cancer was mostly between the age of 30 and 50, as you can imagine. Prostate cancer, we had mostly 60 to 69, and these were mostly patients with metastatic disease at diagnosis and also high risk and very high risk. Interestingly, we had the most BRCA2 patients with breast cancer, which is something that is very different from the Western Africa, African Americans, and also some of the African or female of African descent in the Caribbeans who tend to have mostly BRCA1. And we probably have, without our controls, we probably have one of the highest mutation rate in our patients. I'd want to say in the world, but let me just, limit myself to Africa. We have 18.3%. Most of other countries are still into 14 and so on, which is still a compelling thing. And for prostate cancer, we had BRCA2 mostly, and RECL4 is still not really indicative to prostate cancer or causative to prostate cancer, but it also was found, and also the other few genes that also are causative of prostate cancer were found in our study population. The next slide. So what we've learned and what we're trying to do, if you do not have genetic counseling, do not let it not be your limitation. Some of these things are coming up. We've learned about video for pre-test counseling. We've learned about video for post-test counseling, but our population, for example, ready to look at videos and get the most information. Would the pamphlet make sense to them? Would something that looks like them with I don't know, a cartoon or a woman that looks like them, or maybe one of them who is willing to, you know, give a testimony about what has happened to them with genetic counseling, help them. So this is another way to think of this, and the term for it really is the alternate genetic care delivery. It's something that we're really, really looking forward to. But then one of the bridge to think of, and that we're working on actively at the moment, is to try and understand all of these platforms in an ethical manner. Do patients understand what is genetic? Can we actually test their knowledge? There are tools for that. There is one tool, for example, that was tested at the Dana-Farber called KnowGene. That is one that you can test. You know, you can also test knowledge on cancer itself, and you can also probe what cancer has meant to them, how knowing the risk, for example, what type of emotions, what type of reaction this has brought to them, you know, get to understand whether if this was a test that you're going to pay on what they were going to pay for themselves, how much are they willing to pay? Interestingly, in Nigeria and Cameroon, this is something that has been done before, and most patients, even the ones that are working, have a better life, so to speak, and are middle class, high class. So, for example, they're only willing to pay between $20 and $100, and whoever is in this field, so to speak, knows very well that most of these tests, for example, ours, we paid $200. And I know for color, for example, the lowest they can go to is $250. But these are for panels that are bigger, and we probably need to think of, you know, smaller panels that are very curated and you know, focusing on our population and the type of people that we have. And I'm going to discuss about that later. But at the same time, you really need to do the hard work of training your people and essentially streamlining activities with all other countries that are doing the same work and they have the same issues as you have. So at the moment, we're also thinking of cascade testing and adding in other malignancies. We're thinking of colon cancer, pancreatic cancer, skin, and so on. Also think of solving the growing VUS question, which is still an issue based on the larger panels that we have, and also because our variants are really not known and our population has not been represented in the literature. And we want to gradually shift from research to clinical practice. Another thing is that, you know, from this, we need to engage the insurance. And this is a question everywhere. Are the insurance able to do that? I'm happy to engage on that question later. But really what we need to do is to go from 84 gene panels, 30 gene panels, to maybe something like 9 gene panels, like the Wisdom study is doing here, but essentially focusing on things that are known to the population that you're trying to serve. But of course, also get to be able to share our work with many other people doing the same work, whether on the continent and region. The next slide shows the team that we work with, our amazing, you know, program coordinator, study nurses, study research assistant, medical oncologists, medical geneticists, and the teams pretty much everywhere in the world. This is a very bigger team, as you can imagine. It hasn't been the work of one man, but work with many people. Thank you very much.
Thank you so much. And then we'll turn over to our last speaker, Dr. Fidello, who's going to talk about perspectives in healthcare providers in Rwanda on clinical cancer genetics.
So thank you very much and I'm glad to be speaking with everyone. I know we're running short on time, so I'll try to go through the slides pretty quickly. Next slide. I think some comments that have been left within, some questions that have been left in the comment, sort of indicating that we sort of really need to have a good understanding of perspectives of patients as well as providers. I think that's really key. And this is an example of what we did in the context of the project Dr. Manarikiza just presented. So we did a survey of clinicians in Rwanda, sort of understanding, you know, their own perspectives of genetic testing, what are the current practices and what are some challenges. Next slide. This is just a quick summary of some of the results. So this is a demographic of the participants of the survey. So there were 100 people who participated, mostly doctors. As you can see, most people were under the age of 40, so people who were not necessarily have been in practice for a long time, but relatively on the younger side. Most of the participants were from the capital, which is Kigali. And most of the participants were from the national hospitals. So next slide. So this sort of gives you a sense of what people were really thinking, and also what their prior experiences were with genetic testing. So we asked about formal education, about cancer genetics within their schooling. So this is nursing school or medical school. I guess, as you can see, most people had some form of exposure to cancer genetics. But after folks got into practice, only a small number, only a minority of the clinicians had some form of experience with or some form of experience with education with cancer genetics. So 47%, and even a much smaller fraction had undergone some sort of continuing medical education with cancer genetics. So just highlighting the gap in knowledge that exists in resource-limited settings and places that we can potentially focus on. And we also asked about people's willingness to participate in continuing medical education about cancer genetics, and virtually everyone was interested. We asked about folks' self-rating of cancer genetics. And as you can see, most people rated their knowledge of cancer genetics as less than fair. So really highlighting that in order to facilitate something like cancer genetics in resource-limited settings, given that it impacts or the things that need to be done when someone is positive or when a family member is positive impacts multiple elements within the healthcare system. I'm really highlighting the importance of education of clinicians. So next slide. We also asked the participants which specialties they thought were qualified to offer genetic counseling. I think, as you've heard from the prior presenters, the lack of adequate genetic counseling sometimes can be perceived as a barrier, and really thinking about innovative ways of potentially overcoming that barrier. The participants here felt oncologists and genetic counselors were the most qualified, but also, as you can see, there is also a willingness to train potentially other folks within the healthcare system. And some of the other innovative strategies are potentially using not just genetic counselors, but using videos or other methods at the start for pre-counseling, but then potentially having a more diverse group of healthcare workers for the post-counseling. So next slide. The next slide sort of talks about what they perceived as the most important barriers. And this is not necessarily surprising, but I think quantifying these things, understanding perspectives from healthcare workers, but also understanding perspectives from patients is important. And these healthcare workers thought, the cost of testing, limited knowledge in patients, lack of testing infrastructure were the most were the highest rated as the most important barriers. And there have been some questions in the chat about potentially developing local infrastructure in countries. That's obviously quite important. But until that infrastructure is developed, really thinking about ways of leveraging international partnerships. And this could be regional hubs within which genetic testing can be offered within regions in low resource settings, or like the two projects that were described where there was actually international collaboration with international labs, mostly based in high resource settings. So other things that were identified as potential barriers was also the limited personnel, and this is not just limited personnel with regards to counselors, but just limited personnel in general with regards to responding to the results. And the next slide is the final slide. So just giving you some of the conclusions of the perceived gaps, and to the points that were made in the chat previously, I think really good foundational work, understanding both qualitative work and quantitative work, understanding barriers and perspectives of patient and healthcare workers will really help us in really designing ways of overcoming these barriers if we really want to make genetic testing in cancer something that is more widely available. So I think I'll stop there, and I think that gives us a little bit of time for questions.
Thank you so much, Dr. Fidela. So yeah, I think we have time for a little bit of questions. I did see one main question overlapping and around the choosing of industry partner for cancer genetics testing if you do not have in-country resources. So I can go first, and then maybe Dr. Menarakisa or Dr. Fidela can talk about how in Rwanda you guys chose your genetic testing partner. So for me, as I was mentioning in my presentation, it's really important to get a company that can, one, be adaptable and flexible with your workflow, and because what they're accustomed to in the United States or wherever they're located is probably not the workflow you're going to present. And then two, I think just looking to see what their track record is, like, how many tests are they doing? How old is this company? What are their other academic partners? Who are their advisors? So for me, looking at that, I realized when I first working with Color, they had many academic advisors from, UCSF, Penn, UWash. So looking at sort of their overall package, you can kind of gauge what kind of partner this cancer genetic testing company might be. And then the other question was just costs. And I think because in the US, we're much more accustomed to the insurance paying model, and a lot of countries may not have that. They might have the universal healthcare, the government's providing healthcare costs versus like private where someone pays full out of pocket, as it is in Trinidad and Tobago. I think the safest bet is to just have a system where you're funding the kits. Because if you rely for the country to start providing the costs, you might run into trouble. And of course, if the patient is relying to pay for the test, the cost might be not within reach. So usually for my project, it was getting funding to pay for the test. And that's how we were able to get a lot more with enrollment. I don't know if Dr. Menarakisa or Dr. Fidela would like to weigh in how you chose your genetic partner.
Yeah, so for us, it has been mostly reputation. It was Invitae and, track record. They have their own issues, but track record and how they've been, performing over the years. But then honestly, really, it's been about the costs and the panel sizes they were proposing to us. So as I've said, it was $200, while many others. So we worked with some other labs in South Africa. The quote was $500 per sample, but if you have $200, is much better. And they were taking care of the shipping cost as well and sending us the tubes for sample collection. At the time, with everything that was going on around, that was a very good deal, I'd say. So, but at the end of the day, getting panels, a bigger panel is an issue by itself when you are serving the population that we're trying to serve. And now we've learned better and probably are going to do much smaller panel to start with. So, yeah.
Yeah, I agree with the comments. I think also the flexibility of the partner, like Dr. Geneva mentioned, I think is quite important. Being able to work with the differences, I think is quite important. So yeah.
I think that is our session. So I will turn back over my screen. I want to thank our speakers again. Thank you to our audience. I hope that we're able to give, some insight and some advice from our experiences with our research projects. And I hope you got some nice points to take it away.
Excellent. Thank you very much, Dr. Parkinson, and to all of the presenters at that session. clearly very thought-provoking, as you could all see, also the rich discussion in the chat. So congratulations on your work. Thank you for presenting that here to us. And congratulations again on being one of the 3 accepted scientific sessions for this year's annual symposium. It was really a great opportunity to learn about your work. So thank you for that. And now it is my pleasure to invite you all back to the final Meet the Abstract Authors interactive poster session for this year's annual symposium. This will take place on Gather. Hopefully, many of you have already had a chance to mill around there and are very familiar with it. We will also place the link in the chat for you to find your way over there. Today, the scientific abstract authors from both the oral abstract sessions on Tuesday and Wednesday will be available to discuss their posters in the room marked day 4 in Gather. As a reminder, all of the posters are available in all of the different rooms. I would like to acknowledge and thank all of the scientific abstract reviewers from multiple institutions who supported the abstract review process this year. Thank you for your time and effort you put into that work. And as a reminder, all of the scientific abstracts will be published in JCO Global Oncology in a special supplement together with an editorial later this year. We are, during this Meet the Abstract Authors session, we are going to move the participants to the waiting room in Zoom, but we will keep Zoom open. So we do ask that you please return promptly at 10:50 Eastern Time for the much awaited Rachel Perline Award ceremony and keynote address. We will also make a time announcement in Gather as well. So we will see you back here soon and enjoy the Meet the Abstract Authors session. Thank you.
Good morning, everyone. My name is Franklin Huang, and I'm an associate professor of medicine and urology at the University of California, San Francisco, and the co-founder of the nonprofit organization Global Oncology, based here in San Francisco. Today, it is my distinct honor to chair this session and welcome you to present the 2024 Rachel Perline Global Cancer Award to Ms. Benda Kithaka. This morning, I would like to begin by acknowledging the Perline family, Don, Rachel's father, and Sarah, Rachel's beloved sister. Rachel was incredibly close to her father and sister, her family, and her friends, and we deeply appreciate their support of this award. I'd also like to thank the organizers for allowing me to be a part of this wonderful ceremony and look forward to this event. Rachel and I grew up together in St. Louis, Missouri, and we were close friends throughout life, sharing a love of our hometown, medicine, and Cardinals baseball. Rachel suffered a loss relatively early in her life when her mother died from breast cancer when she was only 13 years old, and this guided her future career. While St. Louis was never far from her heart, she graduated from Brown University and then went to Tulane for medical school, where she also received her master's in public health. Then on to NYU for internal medicine residency, and then she came here to UCSF for her oncology fellowship, where she thrived and distinguished herself in the care of her patients and colleagues. It was during this time that she was diagnosed with gastric cancer, and she was only 38 years old when she died from this disease. Our careers closely paralleled each other, and we would often talk about how to combine together our interests in global health, oncology, and basic research. She was passionate about global health and caring for the less fortunate, and this was immediately apparent to her colleagues. She was also an intrepid and adventurous traveler, working in China and learning Mandarin. And yet she was entirely grounded in her upbringing, in her roots, in her friendships and family, the only person I knew who would call her friends on their birthdays without fail. She believed that caring for others was a privilege, and at UCSF, her presence and absence are still felt to this day. In the time of Rachel facing the adversity of her illness, she was incomparably Rachel, incredibly positive and spirited and engaged. She wanted to let everyone in her life know how much they meant to her. It's best represented in her own words and in her unforgettable smile. There's a video of her final message online to others, and I encourage you all to watch it. It embodies so much of her. This award was established in Rachel's memory, and every year we honor her memory with this award. Today, I am privileged to present this year's 2024 Rachel Perling Global Cancer Award to Ms. Benda Kithaka. Ms. Kithaka is being honored for her commitment and efforts towards caregivers and survivors, and her exceptional advocacy efforts towards addressing the cancer burden in Africa, including cancer prevention and treatment and the elimination of cervical cancer through her nonprofit organization, Kilele Health. Now about this year's awardee. Ms. Kithaka has over 25 years of experience in communications, research, and marketing, and 13 years in health advocacy. Among her outstanding achievements, she's the founder of Kilele Health, a Kenyan nonprofit organization with programs to promote cancer prevention and control using the power of storytelling to harness lived experiences as tools for advocacy. Under the program Kilele Challenge, Benda takes a team of cancer survivors and caregivers to summit Mount Kenya in September every year to highlight cancer survivorship challenges and advocate for post-treatment empowerment of cancer survivors across sub-Saharan Africa. Kilele Health is also the Secretariat for the African Cervical Health Alliance, a network of civil society organizations that is working closely in 16 countries across Africa to support the global WHO call to eliminate cervical cancer as a public health problem. She is also a trainer, facilitator, and public speaker on advocacy for women's health and sits on various global, regional, and local technical working groups in an advocacy and advisory role, including the UICC Cancer Advocates Program Advisory Group Chair and the Africa Cancer Research and Control Echo Steering Committee Chair. She's alumnus of Strathmore Business School, the Institute of Management in Kenya, and the University of Nairobi political science major, and has published in a number of peer-reviewed journals. In recognition of her work, Benda has received many awards, including the Cancer Ambassador of the Year, Kenya, the Kenko Advocate of the Year, the Dicey Scroggins IGCS Distinguished Advocacy Award, and the AACE Selma Morris Memorial Award. A nominator spoke of her tireless commitment to bridge the gap between research and practice, which exemplifies this awardee. She is a mother of 3 adorable children, 2 daughters aged 23 and 11, and a son 13. Currently, she's also pursuing a master's in public health at the Liverpool John Moores University in the United Kingdom. And last but not least, when not advocating, she loves to cook, bake, and eat. Ms. Kithaka, we are delighted to listen to your keynote address today. Congratulations on your award, and we look forward to hearing from you. There will be time for questions at the end, so please put questions in the chat and we will direct them to Ms. Kithaka at the end.
Thank you so much, Franklin, and thank you everyone for joining us today. I am going to be presenting some slides, so as I'm preparing to share them, kindly just allow me to acknowledge everyone who has made this journey possible. I want to start with thanking God for this opportunity and really thanking my family, my friends, mentors, and partners and friends that have worked with me and walked with me this journey. And mostly to thank the survivors, caregivers, and advocates, fellow advocates across the globe, whom today I feel very privileged to represent. Lastly, I want to honor the family of Dr. Rachel Perling, because it's through her that we get this award, and it's through her that we get to experience what we're experiencing today. It's quite an honor for me, and I'm delighted to be here. Now, Franklin, when you were speaking about Dr. Rachel Perling, even I did some bit of research on Rachel. The reason being, I wanted to know the spirit of the person that we are honoring today through this award. And when I was searching, I think I found the same video that you're speaking about on Facebook. And she plays a beautiful song, and the song is Show Your True Colors. Initially, I thought I would come and present to you all about the scientific work that we're doing and the amazing things that advocates in Africa are doing. But Rachel's call to us is to show our true colors. And she reminded me that this year I promised I would be working through authenticity, representing my actions, my words, and the set of principles that I live by, which is authenticity. Rachel's spirit as a health advocate globally, and a survivor herself, even though cancer did take her life, and clearly someone who loved to travel, We've had, she went to South Africa, to Haiti, Romania, China, the United States, and her presence must have brought ripples of joy. In her video, she calls on us to smile. It is a great feeling when people smile back. I do hope you're all smiling today in honor and memory of Rachel. She is someone I would have loved to know, and therefore I'm hoping my slides here today, as I speak about Kilele Health, as I speak about survivorship as a link to prevention, and as I speak about the practice implications on survivorship, we can be able to give her the memory that she so much deserves. About Kilele Health, in 2020 during COVID-19, we went up Mount Kenya the very first time ever for cancer survivors and caregivers in an organized group in Kenya to climb a mountain. It was no mean feat. The photo you're seeing there, I hear if you show people photos, they get to concentrate more. The photo you're seeing is us all wearing masks, going up one of the hills to prepare. And it was meant for us to be an inspiration to show people that there is life beyond cancer. Little did I know at that time that we would actually be setting up an organization that's making ripples across the country and across the continent. Kilele is a Swahili word, which means to peak or to climb or to reach the epitome of our health goals. And it was chosen because initially we wanted just to show people through climbing mountains that you can overcome anything that you set your mind to. And if they can climb mountains with me, then what else is there that we can't do? I think we achieved that. And because of that, we've joined other networks and memberships, including the NCD Alliance of Kenya, the Kenya Network of Cancer Organizations, Union for International Cancer Control, and recently, we've also started the African Cervical Health Alliance as a way of galvanizing action in advocacy across Africa to make sure that we can help others understand cancer is not a death sentence. We are a non-profit. Our vision is a Kenya where people have optimal health and a life of purpose. And what you're seeing there is one group of survivors that have summited the Elephant Hill. For the life of me, I don't know why they call it a hill, because I've never managed to summit it. But the survivors you see there, the youngsters that you see there, all of them summited not once, not twice, but 3 times. And at times they would leave us miles ahead to show that there is a life beyond limits if we set our minds to it. In Kilele, we have 4 programs. We have Kilele Challenge, which challenges perception. We have DEPCAS, which is developing and equipping persons living with NCDs and caregivers to be advocates with skills for sustainability. And we train survivors, caregivers on advocacy, storytelling, so that they're able to use their lived experiences to challenge others and to live a life of purpose. We also have Thamani Yetu, which is a Swahili word, which means our value. And we've chosen that name again deliberately because there is a value that survivors, caregivers, and advocates such as myself bring to the table in policy advocacy, in managing knowledge of cancer, in engaging communities and empowering them to learn about cancer and to take action for prevention, in bringing our knowledge to the table to inform research priorities, but at the same time to also showcase how the interventions are working in the community. And lastly, we have ACHA, the African Cervical Health Alliance, where we're growing networks across Africa. Some of the organizations started by survivors themselves, others by advocates who have lived experience with their loved ones, and others by policymakers who want to make a difference in the continent. We work on survivorship as a link to prevention, and we are also working on research and capacity building and development so that we have a robust advocacy movement in Africa. Now, that photo that you're seeing is the very first photo of the summit. That team, I owe them so much because this is a team that came with me up a mountain. Initially, I wanted to climb Mount Kenya to challenge God. Believe it or not, I was going to confront him and ask him, why would you send me on a mission 9 years and work in this field? And every other day I'm feeling like quitting. But then again, I had also promised God that I would do this work to inspire others towards prevention, but I knew I could not do it alone. We have a saying I think it is Henry Ford who said, coming together is the beginning, keeping together is progress, and working together is success. This quote in me was showcasing how we can work together on advocacy for cancer prevention and control in Africa, utilizing our lived experiences. And so my speech is today divided into 3 segments, where we are coming together, keeping together, working together, and staying together. In coming together, my story starts way before we started climbing mountains with an organization called Women for Cancer. Women for Cancer was founded by 4 women. Some of them are on this call today. And it was coming for me from a lived experience with my sister, who at the age of 27 was told that she had cancer of the cervix. She lived about 200 kilometers away from Nairobi, and I was working in corporate Kenya. And for me, I knew if I bring her to Nairobi, therefore navigate her, she can get access to treatment. At that time, I thought cancer was a death sentence. And therefore, I thought if only I can help my little sister to live a quality life and also help her to overcome. The other day, I was speaking to my sister, telling her that I was going to be quoting her. This is the very first time you're seeing my sister's photo in a public forum talking about cancer. And I asked her, what do you think about stigma? If people come up to you today and ask you, are you the one she's always been talking about? What will you do in the village? My little sister, she's still little, even though she's turned 40. She told me that she has overcome for herself the fear of being known that she's the one who went through this. And she knows the power of people understanding and accepting and being open about their status, that they may inspire others to change. And I think that's a big statement on where we need to get everybody on the survivorship journey. I started out armed with nothing but my sister's story. We would go to the communities, convert classrooms into advocacy rooms. We would convert classrooms into screening rooms. We would get women to line up. And what you're seeing there in the photo is what actually we used to do physically. Until 2013, the story was cervical cancer can be eliminated. And then I went to South Africa for the aortic 2013 and met 2 phenomenal women who were my trainers. One of them is Mom Dicey Sproggen. She passed on last year, but one. And it was quite painful to see that cancer took away this incredible woman. The other one is Miss Kwanele. She lives. And I love that she's taken advocacy to the highest level in terms of legal rights for cancer patients. These are some of the mentors that have taken me to where I am. Armed with the knowledge that I learned in South Africa and armed with the knowledge that I had picked on the various conversations that we were having with women in the community, I knew that we needed to do more to overcome the skeptics that would ask, why are you working in cervical cancer when breast cancer is more known? The ones who would say your place is in the pulpit, not in a scientific community. The ones who would bring the fears that cervical cancer is continuously killing people. And I went back to school to learn health system strengthening so that we can build up that knowledge of cancer prevention into policy action. At the same time, as a volunteer working in Africa, I would by day be an advocate, by night I would be working tirelessly in my consulting work so that I can be able to bring some form of income to my household. I would be attending conferences, but in the evenings, I'm writing brand proposals to support brands in Kenya. And I would be in community outreaches with my team in Women for Cancer, and we would be doing all these outreaches, but I know of the other deadlines that are waiting, tirelessly working day and night on advocacy. But the other thing that I needed to overcome for myself was the imposter syndrome. Most often we would go to these meetings and there are questions about, why are you doing this? You're in this field, you're not a medic. And I know it's a thing that goes on quite a number of other advocates. What you see there are some of the moments that were validating for me. For example, shaking the hands of our First Lady, Her Excellency Margaret Kenyatta, when we did the Beyond Zero campaigns to reach communities with the knowledge of cervical, breast, and prostate cancer elimination. Being called on media as an expert in advocacy, and at that time I'm still learning advocacy, being acknowledged by various experts, including Dr. Julie Graylow, who has turned out to be a very valuable mentor to many advocates across Africa. And of course, being given some of the awards that have been mentioned earlier. But the turnkey points was when our political leadership started paying attention and would invite us to meetings and would invite us to offer technical expertise. And that's when I started seeing the value of bringing our voices to the table so that we can help inform policy interventions, and we can help inform action across Africa. What you see at the middle photo is us signing the first MOU with the county first ladies in Kenya. Health in Kenya is devolved, and we're signing that MOU to take cancer advocacy across the country. In my journey on advocacy, again, I've encountered incredible survivors, incredible caregivers. One that stands out is the Omani Cancer Society. In 2015, 2016, and 2017, they took me under their wing, and they taught me, together with other advocates from across different parts of the world, to be able to advocate vocally and to be able to bring that knowledge to our country. And in bringing that knowledge, it's how we gain the strength and to bring other partners on the table. Some of them working in oncology industry, some of them working in policy making. What you see there was the first high-level advocacy breakfast meeting that we held from a grant that had been given to us for $1,000 by the Weekend Forum. And we brought together the first ladies to discuss just after the elections in 2018, how they could be champions for elimination. You would imagine with all this success, I would be a happy woman. In 2019, we're going to be introducing the first vaccine, the HPV vaccine. Our work was bearing fruit. The national government had taken on the National Cervical Cancer Awareness Month. There before, we used to do it as ourselves, as Women for Cancer. I should have been happy, but I was facing some level of depression because even as we were succeeding, some of the survivors I was working with in the field were actually dying of disease that should actually be prevented. The lady you see with the Maasai attire is Rose Chedo, a woman who changed me tremendously to see the value of survivors and to be able to recognize that we need to work with survivors, not just in advocacy, but also in quality of life. Rose, together with other survivors, had walked the journey with me in the trenches, sharing their stories, sharing their lived experiences. And for them to die of cancer was sort of like a kick for me to ask me, yes, you're telling people, go get screened, you will get better. But what about survivorship? What about quality of life? I forgot to mention, in 2018, my grandfather was told he had cancer, Kaposi's sarcoma. He didn't have any risk factors or any signs and symptoms because, for example, he was not HIV positive. Most often people will tell you Kaposi's sarcoma is, HIV and AIDS is a defining condition for Kaposi's sarcoma. But at that time, my grandfather, a church man, didn't have HIV and AIDS. And yet he died in 2018 of Kaposi's sarcoma. And I had seen him lose his memory, a man who was very lucid up to and including the period of the cancer diagnosis. Due to some of the interventions, he started losing his memory. He became frail. His nutrition was affected. And so I knew quality of life needed to be addressed. And so in all this questioning, that's when I thought I would go up the mountain and confront God. And who is God? I can tell you. When I said I'm going to confront and I put a challenge on him, INEOS was happening. And if you all remember, Eliud Kipchoge was running the sub 2 hours challenge. And he did. And I watched it on my dining table and I asked, if he can do it, why can't we who have been saying we want to surmount this mountain of cancer advocacy, why can't we do it? And 2 weeks later, I was standing next to him because I had said, if I meet him face to face, I will climb Mount Kenya. And now because I had said that out loud, I needed to prove right. This is where we come to working together with survivors. By committing to climb the mountain, even though Rose was no longer alive, and even though we had had great plans about climbing together, I knew in this journey, she was still with me. By the way, today I'm wearing blue beads. This one made by Rose. She used to do very beautiful beads and she would give me as gifts because she said, that's all I can give you. She brought her lived experience on the table. So even as I honor Rachel, I want to honor Rose and all the other survivors that have passed on due to cancer, but also to remember them and to say that their lives continue. They still continue impacting others through the work that we're doing, meaningfully engaging survivors. In 2020, amidst COVID, we had started preparing. We were already doing the gym. We were already working out in readiness to climb the mountain. When COVID came, we stopped preparing and we started looking for food to make sure that the survivors have livelihoods. We started looking for masks to ensure that we can get them to continue getting their treatment. I remember one woman who was put on quarantine for 14 days, and she actually passed away in that quarantine because they said she has a high fever, she has all the signs of COVID. It wasn't. It was the cancer that was causing all these signs and symptoms. As we were doing so, we were still resolute on going up the mountain. And I can tell you that through the grace, we were able to train. As much as we didn't have the full gear, as much as we weren't able to get the right equipment, we had an amazing hiking team and we were able to write our stories on Facebook to show people what can be done when a team comes together to want to confront the mountains that face us. And what are those mountains? Policy. Getting to get people to understand the challenges of survivorship in Africa. We held 2 workshops in 2020, 2021. And I've seen the output from that because in that we've gotten more and more people joining in survivorship to be able to study survivorship in Africa, to be able to bring knowledge on survivorship, to bring interventions on survivorship. And I can say that with these 2 workshops, we're able to change mindsets. Equipping participants with both mental wellness, coaching, as well as self-care so that we can reduce stigma, we can reduce fear, we can change narratives on cancer. And what we've seen from our survivors is they reported better sleep, better management of their own side effects. Some maintained their weight goals, or even some gained weight if that was their objective. Others lost weight if that was their objective, and all of it to be able to manage their quality of life. I myself lost some bit of weight. I said, I think Franklin mentioned I love to cook and I love to eat. And so that weight needed to come off as well. But the bigger impact that we saw from our programming was that more and more survivors were now willing to engage in policy advocacy, engage with the government to bring the cost to the table. We were also able to register more and more media coming on the table and covering more stories. To date, Kilele has had more than 100 media articles that talk about cancer, survivorship, lived experience, prevention, as well as HPV vaccination and cervical cancer elimination. One thing that I regret in my journey for advocacy is even as we are reporting all these results, one pillar in survivorship quality of life is financial wellness. And that has continuously been a gap for us because one, it's very hard to have a return to work formula for people who have lost their livelihoods because of cancer. Fear and stigma are still there. Some of our survivors will need breast prosthetics to be able to bring them to the table and to be able to give other women who are going through breast cancer. We had dreams and lofty ideas about how we could monetize our experiences and even come up with products that can be put on shelves that survivors themselves can be able to consume. But lack of finances to start these programs put a halt to that. And so in 2022, knowing that we could not continue doing the same thing and expecting different results, Thamani Yetu was born, our value. And what we said is, all we have is a story, but we're going to make sure that that story makes sense. I must acknowledge people who heard of us, sent us links to grants for us to apply, sent us networks that we could talk to, that they may be able to fund some of the activities. I also want to acknowledge the corporates that we knocked on their doors in 2022, 2023, and they were able to come together and tell us that we can walk this journey with you. Some of them I would like to single out Find being in Geneva, coming to Africa, wanting to work with communities. That has been the reason why we've cascaded our work all the way across Africa to 16 countries today. I would want to single out some of the pharmaceutical companies that have worked with us to be able to help us equip the survivors with knowledge, and they can go to the community and talk about cancer. And that is how our advocacy journey is evolving as we go along. So far, we've been able to engage with government. To the highest level, the Director General was opening our meeting this year, where we held a training for women advocates, male advocates from 16 countries in Africa here in Nairobi. We have Her Excellency, the Governor, Cecily Mbarire in Embu County, where we're running one of our programs, who has chosen to be an advocate at the forefront. And what is interesting is she's also the leader of the government, of the political party that's leading in government today. So we know through our advocacy, we have the ear of the highest office in the land. In advocacy, we also engage community, but realizing that I myself as Benda could potentially not do as much as the survivors do, we're equipping survivors with knowledge and skills that they may go to communities, become community health promoters, sensitize others. What you're seeing there is Joanne, one of our lead advocates in Marsabit County, which is about 500 kilometers away from Nairobi, talking to other community health promoters to equip them with knowledge that they can take to their communities across the county. And it's a vast county. So what is our reason and why are we doing this? If I show you, what you will see on many scientific slides is the continuum of cancer control, and it is very orderly. We start with the disease, we go to prevention, detection, diagnosis, treatment, survivorship. It's supposed to be a straight line. But in Africa, it looks more something like something my daughter, who is 11, would have drawn when she was 3. And that squiggly line shows the patient journeys that our survivors and caregivers have to go through to seek treatment for their loved one. What you're also seeing, and it's showing that my internet connection is stable. I hope you can hear me. What you're seeing there is why we have chosen to concentrate on survivorship, because if we equip communities at the community that you can get screened early, you can get treated early, but we are not equipping the healthcare system with policy advocacy to ensure that they go through the system in a linear progression, then quality of life is not guaranteed. Some of the things that inform survivorship include this disease staging, the age of the patient, the overall health, their immunity, the type of cancer, and the treatment modalities. And what we have seen in our region is that the economic stability of the family becomes a social determinant. Their education level, which shows whether they will take up the modern conventional treatment or they will choose to go to a traditional healer for cancer treatment, the healthcare access and the distances they have to travel, the environment and the neighborhood in which they're living, and the social and community context. We often say where people are born, where they live, where they work, where they play, should not affect whether they live through cancer. But we also need to take this message to those places where they are born, where they live, where they work, so that we can be able to equip communities with knowledge of how to prevent. And so with survivorship in Africa, what we are missing is that link where after somebody has gone through the healthcare system, has seen what challenges are there, has seen what is possible, can go back to the community and be the link that closes the gap for the community to tell people, please prevent if you can, so that the healthcare system can be able to take care of people as it should. And so with Kilele, the 4 pillars are geared towards that. Challenging survivorship so that survivors themselves rise up, equipping survivors with knowledge and skills for advocacy, motivating them by recognizing their lived experience as a monetizable tool, and being able to equip them to grow their network at the community level. Why Africa? We've seen it in HIV and AIDS, we've seen it in polio, in TB, in combating hunger, combating poverty. We've seen it that community action bridges the gaps in our communities. And so for us, we're working at how can we ensure that we're seeing more and more younger girls, younger men getting cancer? How do we ensure that their quality of life is not affected? How do we ensure they can live longer to tell their stories? How do we impact survivorship so that we can link it to prevention and we can show more people surviving? In Kenya, we're working in Marsabit, Embu, and Nairobi. We are working in healthcare facilities so that we create capacities, and so that if we were for any reason not able to continue the programming, the county government is able to continue with the services without stoppage. We are working with community health outreach so that more and more communities understand their risk factors and they are able to advance towards early detection, timely treatment, and preventative mechanisms, including HPV vaccination. Across Africa, we have grown. We are in 16 countries right now, with 22 organizations already vetted and another 56 in the pipeline being vetted. You can imagine the population of people that we're reaching. For example, Nigeria is one of our member countries with a population of 200 million, over 200 million persons. And smaller countries such as Lesotho that has 2.1 million, or Rwanda that has 12.9 million people, but has been one of the countries that has the best uptake of preventative measures for cervical cancer, and therefore we can be better able to learn from it. As I speak, ACHA is now 6 months old. Some of our organizations, such as LENASO, has been around for over 30 years. Other organizations are as young as ACHA itself. And we are working on 5 pillars: advocacy and research, capacity building and training, community engagement and outreach, communications and standardized IEC materials that speak to the challenges in Africa and the interventions in Africa, as well as partner engagement so that we can resource mobilize. We are on ACHA, we have 3 partners already: Cancer Research UK, FIND, and of course, Kilele Health, which is the secretariat. But we're still looking for more partners so that we can be better able to create lasting awareness, demand creation for uptake of interventions, and navigation for access to services, but at the same time, entrenching advocacy in the community that communities can demand for governments to implement the 90-70-90. The governments can invest in global breast cancer prevention and treatment, and that we can also combat poverty, which leads to worse outcomes in health. But at the bedrock of all this is so that we can be able to also give meaningful engagement of our survivors as champions for elimination. We look at our advocacy journey as informed by living a life where we are living in an inclusive, equitable world, where our stories change the world, where we are overcoming the challenge of cancer, and Africa doesn't have to lead in that. What we like to say is that we're not giving a handout, we're giving a handout. And therefore, when you join us, you're joining us so that we can be better able to equip our participants, our communities for advocacy through training, through community engagement, and through purposeful, meaningful engagement. And lastly, our network is growing and we work through partnerships. So I invite you to all join us in our partnership. Those are some of the organizations that have worked with us and continue to work with us, and some of the networks that we are in. It's a lot of talk, but I would want to leave you with some of the testimonials. For example, one of our survivors said, personally, it has been an eye-opener to me. I can't regret the breaking of sweat, blood, and bones. And overhaul, it was a total overhaul. Mentally, I'm able to look at things critically and question issues. Physically, my body, physically worked on my body and tested my limits. I'm glad I took this opportunity. That's on climbing the mountain. Another survivor has mentioned, Kilele has been a pillar of hope and strength to me and many other survivors. It has helped me shape me, not just the physical, but my mental tenacity, my business acumen, and the spirit of not giving up. I am not alone in Kilele. I work with a team that is dedicated. We have a board of directors. We have technical advisors who advise us on policy, on research, on legal matters. And we have an able secretariat that is working with over 200 survivors in our network. My team combined, we are 16 of us, but we're reaching 200 plus survivors in Kenya and over 10,000 persons across the Archer network. And so for the Archer network, we have a steering committee of members who are coming from different countries that are members to Archer, and Kilele is offering the secretariat so that we can continue being accountable to our partners. We bring transparency and ethical conduct, and they bring the technical expertise and diverse representation to the table. My invitation to you all today. In Africa, we say, if you want to go fast, go alone. If you want to go far, go with others. My ask of you is to partner with us. And I'll tell you what partnering means to us. Meaningful engagement of survivors, survivor organizations means breaking silos, means bringing inclusiveness. And I want to appreciate the oncology fraternity in Kenya. When I came to the field, I came with nothing but a story. But they have integrated me and welcomed me to the fraternity in such a way that we're able to sit on tables and engage as peers and engage as technical experts, each bringing their own experience, including the survivors bringing their lived experience. I want to single out Dr. Chemtai Mungo, who in 2022 November, just when Kilele was still struggling to bring in any resources, saw a grant application and wrote to me, I think it was at midnight, and said, Benda, this looks like you. You have to apply for this. We applied for that grant with Prevent Cancer and we got it. And that is how come we're able to run with Thamani Yetu, together with our partners, MSD, Hologic, and Roche. This kind of support is what partnership is about, because we're bridging gaps, but we're bringing inclusiveness as well. I also want to point out that from our program, we've showcased it's possible to change the trajectory of survivorship and caregiving in Africa. It's possible to demystify cancer. It's possible to engage, integrate, and equip survivors with their lived experience. They become qualified by experience to go back to the community and say we can prevent, and also go to policymakers and demand for investment in cancer care in Kenya and in Africa. What are the opportunities and gaps that I see? Even as we're doing this work, one, this award gives me an opportunity for us to stop winking in the dark. We are all here, we're hearing this story, and I'm hoping it inspires you to start thinking, where can we bridge the gap in education on cancer? Be it in technical expertise, be it in healthcare worker training, or be it in the community at the patient level, be it at the family level, where can we bridge that gap? Psychosocial support. Kilele has supported survivors to be trained as counselors. But after the training, we are now stuck with, where do we deploy them in health facilities where they can start giving psychosocial support, helping reduce anxiety, helping our healthcare worker to reduce the lines that are waiting to see them, because they can be able to give that psychosocial support. Monetizing that is quite a challenge. Long-term treatment complications. I would love, for example, to have researchers in Kenya and Africa that study lymphoedema or other issues relating to long-term survivorship issues. But our funding is usually 1 year, and we don't even know whether we'll get the next tranche of funding. Is it possible, for example, for the NCI US or any other funding organization to invest in 5-year cohorts research that can be able to bring such knowledge that informs the next interventions in cancer care and in cancer survivorship care?
Focusing on women's health, integration is important because when we think about the woman that is coming to us for cervical cancer elimination, it's the same woman who should be handling the issues with breast cancer. It's the same woman that needs to go to know that she needs to go and take care of her daughter and get her vaccinated. It's the same woman who can go as a tool to educate her husband about prostate cancer. How can we integrate women's health holistically as opposed to body parts and areas of intervention? Lastly, in Kilele, we've climbed Mount Kenya twice, we've climbed Mount Kilimanjaro once. We've not gone again last year because resources. Because in funding, it's easier to fund our community outreach than it is for people to actually give us resources to do the mountain climbing. We have to do crowdsourcing. Again, and ask, could we partner that we are able to show how such interventions such as lifestyle modifications can be utilized in the African space to also combat NCDs and to be better able to equip people for health? Lastly, some research opportunities. Recently, we were just published on our cancer stigma research. And I have to thank my team for being resilient. We were turned down by 3 different peer-reviewed publications, and the last one that accepted us published in April. This research was done on the Kilele Health participants cohort. My ask is, could we extend that to other cohorts, maybe even work with control cohort that is not cancer survivors? Because in the cancer survivorship space and in our survivors who are already sensitized on advocacy, for them, they don't see stigma because for them, they are able to talk confidently about their disease area and they're able to educate the community. But what about stigma in the community? As I come to a close, there are 2 things I want to leave you with. The first one is Kilele Health has this program, Tamani Yetu. We hope to reach 4 million women and girls by 2027 through advocacy. And the second one is the ACHA, African Cervical Health Alliance. We're working on a scorecard to inform the gaps that exist in cervical health and the gaps that we need to bridge for us to reach the 90-70-90 by the year 2030. I would welcome all of us to be able to think, how can we collaborate with civil society organizations? How can we fund civil society organizations as the first port of call to reach communities, but at the same time as the first mechanism to bring back feedback to the scientific community? I remain grateful for this opportunity. I remain grateful for this award. And I'm genuinely hoping in years to come, it can also come with a grant so that other advocates can be able to advance their work as we are doing in Kilele Health. And because this is a door you've opened to us, that we are able to sit on the table with all of you as the scientific community, equip us and capacitate us to be better able to continue doing the work that is mindful of the situations that we work with in Africa. I'm grateful to the people who nominated me, and I'm grateful to ASGCR for this opportunity. And thank you so much for listening to me. Thank you. Back to you, Franklin.
Wow, thank you, Venda. That was phenomenal. And thank you for taking us on that journey. And certainly, you've shown us what a powerful voice you've given to this work, and it's incredible to hear about it, and congratulations on all that you've accomplished so far. I thought, one question would be, given this year's theme of the meeting of collaborating for impact, you spoke to this a bit, but how can the cancer research community better collaborate with the advocacy and survivor community to be inclusive of different perspectives and seeing beyond credentials, and you spoke to this, and I'd love to I think we'd love to hear more about that and what your ideas were, informing potentially down the line in areas where you see gaps. You talked a lot about bridging the gaps, and I think that's a key area where our cancer research community trainees would love to understand what are the interesting questions that we can try to work together on.
I have a few ideas, and one of the things that comes to mind immediately,
besides the resource capacitating, so bringing resources to the table that civil society organizations can be better able to work, there is also the technical expertise. Okay, like in the Archer community, with support from FIND, we've been able to train we have been able to train leaders of organizations across Africa on research methodologies. The thing about this training is it's teaching the community to go fish for information in the community, to bring evidence base on the table, to inform policy and to inform our messaging. If we work together and we start looking at, for example, the Young Investigator Award that you have in the NCI US, it's often geared towards oncology fraternity. It's often geared towards the practitioners in medicine, clinicians, but not as investigators in civil society. I am having to study a master's course right now, not because, well, I do need more education, definitely, but I also want to be able to be a principal investigator, because with my degree in Bachelor's of Arts, it is not an opportunity that's going to come to me because I don't have a title at the front that says doctor. And that's the reality of many people in our continent, that self-limiting beliefs are there. We start imagining that it can't be for us. But secondly, there is the ceilings that have been set on who can be given awards and who cannot be given. So I'm appreciating ASGCR today that this opportunity has been open to us. What I'm asking is, give us the technical expertise that we may also be able to build capacity to do research authentically from our region. Secondly, when we look at our education system, most often the survivors who are working are not necessarily equipped with any technical expertise. They have started with their lived experience and they have said there is something I can do. Let's have advocacy trainings that are geared towards this body of community of practitioners, that we can build a body of knowledge that they can be able to instill further advocacy into the community. I want to applaud Dr. Graylow, Julie Graylow, because from 2012, she has been running the Weekend Forum, the Women Empowerment Cancer Advocacy Network, and that's how come Eve and I got into that network across Africa. If we had more such programs that are also built with capacity and with grants that are multi-year, then we will stop working. You know, how we work is scurry, work, and then stop to look for resources, and then start again, scurry some more and work some more. It brings disjointed action. But if we had continuity, those are some of the things that I would ask of the scientific community. And lastly, in publications, because one of the biggest regrets I have from my work in 2012 through to 2019 was that we would go to communities and set up laboratories in classrooms with clinical cytologists, and they would read slides on the ground, and they would be able to report on the ground, and any suspicious slides would be sent as a photo to our expert in Nairobi or any other place for them to be able to give us a result, and then we can be able to report in the field. That was never documented, because we didn't know that we needed to be documenting that. For us, we were doing good work, we were patting ourselves on the back, and we were getting back to the community saying, we saved one woman, we're happy. If only that was knowledge that is not anecdotal, but it has been published, so that we are able to show how then we can be able to continuously innovate in the community and meet the needs of the community. I hope that answers you, Franklin.
Yes, very much so. That's what I heard, you say and talk about using lived experiences, thinking about how to improve, access and inclusiveness of advocates, and then, the different gates that we have in our communities, and trying to sort of change those gates in terms of, how we fund different types of activities in the community and bridging those gaps. So I think that was very, very meaningful to hear from you. One quick question was, somebody asked about, well, how does someone join ACHA? Like, what are the ways in which folks who are listening to it. And I hope you have a chance to look through the chat. There's dozens and dozens of congratulatory messages towards you. But what are the ways in which different either trainees or advocates or researchers and practitioners who are on the call today might be able to engage with ACHA or join, and what are those requirements that you might speak about?
So I have typed on the chat right now our website, as well as the ACHA website, which is the link for you to be able to express your interest in joining ACHA. What we're doing, and this is again something that was an eye-opener for me. When we started with ACHA, it was referral snowballing, who knows whom, and therefore can be able to join the network. But as we're growing, we're getting more and more inquiries on how people can be able to join. The one thing that we're very clear on is that we are building stringent mechanisms for vetting so that we are allowing credible organizations or individuals to join the ACHA network, because the last thing we want is one bad apple coming in and spoiling the entire barrel of apples, people who are doing amazing and incredible work. And so once you send that email, that message on the link that is provided from the ACHA website, we will be able to have a team vet, call up, follow up, and be able to write an email then on how you can be able to join ACHA. And there are four ways that you can join. You can join as a friend of ACHA, where you are working with us from a technical expertise, if it's a speaker on our panels, or if it's a technical expert who can help in any field, be it research, be it in fundraising or resource mobilization. So as a technical expert, as a friend of ACHA, in fundraising, because we need to capacitate our organizations to be able to continue with the work that they're doing, or as a technical expert who can give your skill set that we may be able to build the ACHA scorecard that will inform cervical cancer accountability to our governments across Africa. And of course, if you scout any opportunities, please reach out. My email address is on the slides, and I'm also typing it again so that we are able to see how we can work together to continue with the momentum that we're building, and we welcome ideas around anything that you feel we can also do together. Lastly, include us in your researches. We have experts in the field qualified by experience. We have experts in the field who have been working for very long. They can be the entry point to the community. Please write to us.
That was great. In terms of, I think you spoke about bridging these gaps, and I'm curious, if for trainees and for people who are beginning their work in cancer research and in the global settings, what would you like them to think about as they, embark on their different research projects or working in the community, or even, obviously there's people working from the bench all the way to in the field, and curious what kind of, advice you would give to them as they think about these types of projects that they're going to begin.
I would take them back to Rachel Carline. Rachel immersed herself in the communities that she was serving. If I read correctly about her experience, she was going as one, she was a scholar, global scholar, who was working on a funded project to be able to bring evidence base to the table, a Fogarty International Clinical Researcher scholar. I would say, as opposed to doing research from what I've seen sometimes, which is let's do a retrospective study, let's do a desk review, literature review, let's get to the communities. Come work with us for a month, immerse yourself. Of course, we won't be able to fund that travel. So we'll come back to the funding organizations to say, could you support the students so that they may get this immersive experience? Secondly, consult the people that you want to change their lives. Last year, we did a study on IEC materials. We found 1 million plus IEC materials on cervical cancer alone.
Majority were not even talking to the disease. There were calls to action, come get screened. But because we did a search online, IEC materials for cervical cancer, they came back as IEC materials. And that's how come Kilele Health, together with FIND and the Archer Network, is working on a standardized IEC material for across Africa. If we immerse ourselves with finding the evidence, we'll be better able to respond to the challenges that we want to solve, as opposed to imagining the hypothesis and working on it from a different place altogether. And lastly, our organizations are in 16 countries. So we're not just inviting you to Kenya, we're saying you can go across Africa if you wanted to find immersive experience. The only thing I will ask is put your mind on how else can you add value to the organizations that you're visiting, so that it's not just about taking, but it's also about giving back to that community that you're working. I think Rachel demonstrated that very well.
Thank you, Benda. Before we close, I think I'll just read a message in the chat here from Sarah and the people you are helping through Kilele is amazing and so very inspiring. We are so grateful and humbled to see this kind of invaluable work associated with Rachel's spirit and memory. Thank you for everything that you do.
Thank you so much. Thank you for giving Rachel to the world. Thank you.
I will turn it over to Satish Gopal to close our session. Thank you very much, everyone, for listening.
Thank you.
Terrific. Thanks so much, Franklin, and thanks so much, Benda. Let me also take a minute to just congratulate you on being this year's Rachel Perline awardee. I have the difficult task of speaking after Benda and also of trying to close the meeting. But I'm grateful that I'll just have a few minutes to do that, to sort of reflect on these 4 days. I always look forward to this day each year when I have the opportunity to feel inspired by Rachel Perline, who unfortunately never had the opportunity to know personally, and also by the work of our amazing Perline awardees. And of course, Benda is the most recent in that very storied line of awardees, and the first from the patient advocacy and survivorship community, which I think really reflects the growing importance, recognized importance that has been neglected for far too long of that community in the cancer research enterprise, and want to thank her for a lot of her kind of provocative ideas and comments that she really tasked us with to consider as we move forward in our activities. I would like to start by thanking a few people. So first, thanking all of you for joining, which I think is really important. I think we've had people joining from truly all over the world, from many different time zones. I'm aware that I'm standing in between some of you in lunch and some of you in your beds, and so want to really just express appreciation from all of us. Thanking all of you for joining. I wanted to thank our day 4 speakers throughout the day today. I think the scientific session, the flash talks, and then culminating in Benda's Perline awardee address. I think this has been a really outstanding final day. I'd like to thank the steering committee, in particular representatives from all of our various partner organizations that you've seen featured throughout this year's symposium. We really benefit from and appreciate their involvement in the development of the symposium each year and working closely with us at the NCI. There are a few people who I'd like to just call out individually, if you will indulge me. There's a few NCI colleagues who've spent a lot of time and effort developing the symposium, and I think deserve a little bit of specific recognition. So first is Mishka Kohli-Sira, who has led the scientific steering committee and really shepherded meeting organization overall. And of course, you've seen her throughout these 4 days and in many communications leading up to this week. So great. I just want to express sincere appreciation for Mishka. Lindsay Eldridge led the abstract and scientific session submission process using the GatherTown platform. I think that's a platform that I continue to be amazed by every year, and really enjoyed, even this morning, having the opportunity to ask questions about a specific figure on someone's poster who was describing their work to me from halfway around the world. I think it's really remarkable to be able to interact with each other in that way around our work in using this platform. I'd like to thank Sudha Sivaram, Yelena Schneider, and Sana Heather for leading organization of the Early Career Investigator Day, which began last year and I think continues to be a really important part of the symposium overall that we're committed to continuing. And then our entire NCI ASGCR team, including Paul Perlman, Doug Perrin, Nina Ghanem, Lillian Matthews, Lydia Wilson, John Bellafiore, and others who've really worked tirelessly over the past many months to put this meeting together. Today, we've had, I think, terrific sessions today, including the Gather Town Meet the abstract authors, and then culminating again in the Perline awardee address by Ms. Benda Kitaka. We at the NCI think the Annual Symposium on Global Cancer Research is really important, both at the NCI and at the Center for Global Health. Of course, there are many cancer research and global health meetings throughout the year, but we've really tried to cultivate this as a specific offering in the landscape of cancer research and global health meetings more generally. We think we have a tremendous platform at the NIH and the NCI as the largest funder of cancer research in the world, and the largest funder of global health research in the world. And indeed, I often think feel really proud that the NIH and the NCI have throughout their history been such important supporters of work all around the world, which is very different from biomedical research funding agencies in many other high income countries. And I think that's something that we feel very proud of and are committed to growing and continuing. Partly that's reflected in the establishment of a dedicated Center for Global Health at the NCI in 2011, which I have the extreme privilege of joining 4 years ago in 2020. And what we've sought to do with our many partners and with all of you is to try to create a scientific meeting for which there's virtually no barrier to participation, and that includes timings and language, which we've thought to really try to increase inclusivity in recent years. We've scheduled this at a time that is actually somewhat inconvenient for our US participants joining from the West Coast. So I want to thank Franklin Huang and others joining from the West Coast very early in your morning, but we've really sought to set this meeting up at a time where people from Africa, from India, from Asia, East Asia can join without it being too inconvenient. We've also really wanted to invite and ensure that people who are working on cancer research and control anywhere in the world feel engaged in the cancer research enterprise as supported by the NCI. And so that's been an important goal and continues to be an important goal of this meeting. And then finally, we really want to use the NIH and NCI platform and visibility to highlight work and people who are doing the work, particularly in LMICs, that may not attract similar attention at some of our larger cancer research meetings. And so that continues to be an important purpose and goal of this meeting in particular. With that continued commitment from the NIH and NCI and the Center for Global Health, I'm really delighted to announce that we already have dates for 2025 for next year's Annual Symposium on Global Cancer Research, which will be Monday, May 5th through Thursday, May 8th, 2025. So please do mark those dates, and of course, more communication as we towards next year's symposium will be forthcoming. We'd invite all of you to provide feedback on this year's meeting as we start to think about next meeting, completing the post-conference survey. And I think there'll be a slide coming up next with the survey link and QR code, which has been shared throughout this year's symposium. This feedback really is very, very important to us. We've tried to incorporate this each year in continuing to evolve this symposium as, again, a critical activity, dissemination activity that we at the NCI and the Center for Global Health remain committed to. And so please do, as you have time, share your thoughts on how the meeting and its content can be improved in subsequent years, because that really has helped us evolve the meeting in ways that we hope are serving the cancer research community around the world. So with that, let me thank you all again for officially for joining us during these 4 days. Apologize for the few technical difficulties that we've had here at the end. Thank our many partners who are for whose participation we're extremely grateful, as shown on this slide. And then just invite all of you to join us next year at the symposium. I look forward to seeing all of you at ASGCR 2025, and perhaps virtually or in person at various other meetings between now and then. So thanks everyone very much again, and let me take this opportunity to officially close ASGCR 2024. Thank you.
U.S. Department of Health and Human Services, National Institutes of Health, National Cancer Institute, cancer.gov, 1-800-4-CANCER.